Good morning, everyone. We are really excited to have Dr. Annie-Claire Nadeau-Fredette from Montreal present to us on PD transitions, on home dialysis transitions, I guess. She is an associate professor in clinical medicine at the University of Montreal and a research scholar. She's the director of home dialysis at the Maisonneuve-Rosemont Hospital. Her research interests involve transitional periods, especially in patients living with kidney failure, especially those on home dialysis. She's got over 80 papers. She's involved in several national and international efforts in this area, and has leadership roles in SQN, ISPD, and CORE. In particular, she got the 2020. She's the 2024 recipient of the ISPD John Maher Award, which recognizes young nephrologists who have contributed substantially to the field of PD. Welcome.
Thank you. Just gonna share. So thank you very much to attend this early session. We're going to talk about home dialysis transition, but also understanding the patient points of view. So these are my disclosure. You can interrupt me at any time if you have questions. It's all good. So the objective will be to highlight practice pattern, risk factors, and outcome of home dialysis through large registry studies, to discuss important outcome for patient transitioning to, from, and between home dialysis modalities, and then try to characterize patient perspective during the transition to and from home dialysis. So this is the timeline. So we'll start by discussing PD or home hemodialysis. So years ago, when I started my home dialysis fellowship at UHN, there was all that question about PD, home hemodialysis, what was the best modality, what should patient do? And I think at this point, we don't really care about specific details anymore. We know that there are one modality that may be best for one patient at one specific time. But these are just a summary of some of the benefits. We did still try to assess outcomes of patients starting on PD and home hemodialysis. So this is an old study that I did when I was doing a fellowship in Brisbane in Australia. And we compare patients starting directly on PD or directly on home hemodialysis or within 90 days. And the first thing that you can see here is that all the baseline characteristics are statistically significantly different. And it's also clinically different. So you don't have to see the details, but it's all different. But when we look at the outcomes, as expected, patient on home hemodialysis had a much higher survival at 5 years compared to patient on PD. And this remained true when we adjust for a number of covariates and using different statistical modeling approach. So patient on home hemodialysis had a mortality result that was more than 50% lower than those on PD. Do we really care? I don't really care. So my own PD program is about twice bigger or even more than my home hemodialysis program. And I think it's probably the same in most centers through Canada. So I think this difference exists, but we should not guide our treatment with that. But then a few years after, we wonder, well, we saw that association in Australia, but is there a difference over time? So does the same association remains there as the year goes by? So we compare this time core data, so Canadian data, again, home hemodialysis and PD, but here we stratify by era, so 2000 to 2005, 2006 to 10, and 11 to 13. And as you can see, the mortality risk, the interaction p-value was not statistically significant, but it was quite close. And you can see that while home hemodialysis was associated with a lower mortality, the association was attenuated over time. And when we look at transfer to hemodialysis, so here we said treatment failure, but it should probably be labeled transfer to in-center hemodialysis, the interaction p-value was statistically significant, and you can really see a change in the association over time. This is likely related to difference in the characteristic of patients that are included into home hemodialysis and PD, especially home hemodialysis as we become more used to that therapy. Other study of note one by Jeff Pearl showed that the technique survival of patient on home hemodialysis changed over time in Canada, probably because the characteristics of the patient were different. So when we look at the crude mortality rate and crude rate of transfer to facility hemodialysis, as you can see, the rate for home hemodialysis was quite stable over time, but it was really a decrease in the risk of mortality in the PD cohort and a decrease in the risk of transfer to hemodialysis in the PD cohort. So it's really outcomes in PD that are getting better. It's always good when you can see that other groups are showing the same association than you are, because this means that it's likely true. So a year later, there was a study from Australia and New Zealand by Mark Marshall showing the same association. So here you have the crude mortality rate over time. The black here is home hemodialysis. So as expected, the mortality rate is lower. Black, you have red is in-center hemodialysis, so facility hemodialysis. You can see a small improvement over time, and orange and blue are PD, so APD or CAPD, and you can really see a decrease over time. And when you look at the adjust model, reference being in-center hemodialysis, you can really see that home hemodialysis is always lower in terms of mortality rate, but the association with PD has been improving over time. So the difference between PD and home hemodialysis is likely not as significant as it was before. So we may be improving our outcomes overall, but especially for PD over time, but there is still a variability. You probably know this study by PDOPS from Mark Lambie, who looked at the median time on PD in different countries. So you can see UK, their median time on PD is 1.7 years. Japan is 3.2 years, and Canada, we are in the middle around 2.2 years, which is quite consistent with my own clinical practice. But what's interesting is that there's a reverse association, as we clinically know, but it was good to show it, with the proportion of patients receiving a kidney transplantation at 3 years after PD. So UK have a really high rate of transplantation, which means that their good patient will be removed from PD, and hence their median duration on PD is shorter. But in Japan, because you don't have as much transplantation, well, your patients stay on PD longer. Here you have the distribution of the outcomes over time. So I've put a square around Canada. And at 5 years, we can see that over 40% of the patients are transferred to hemodialysis, about 20% are dead, and 20% have a kidney transplantation. This is quite consistent with my own clinical practice, and we can see the difference in the different countries. We like to compare ourselves to Australia and New Zealand because they have a similar practice pattern. So that's one of the reasons why our outcomes are similar. It's important to note, though, that while we have increased our survival outcomes of patient on PD, this is the right side figure here, the rate of transfer to hemodialysis is not consistent over the year. Core here is the Canadian data. So as you can see, when we change the year, so from 2000 to 2014, there's an increase in the proportion or rate of patient transfer from PD to hemodialysis in Canada and in Europe. But this association, so the rate decrease in Australia and New Zealand and US during the same time. So it's not exactly clear why these outcomes are different. It may be due or related to the characteristic of the patient that we are now including on PD. It may be because we have more acute transfer. So we don't know exactly, but this remains an important problem that we are not improving as much as we could. We also know that there is a variability between centers for the transfer from PD to hemo. So this study is from Australia and New Zealand, and it was done just after I left Australia. At that time, Australian deferred technique failure as either transfer to hemodialysis or death. So these data here include both outcomes. But you can see in green here that there's quite a large variability in the hazard ratio of transfer to hemodialysis or death among different Australian centers. You have 50 centers, and there's a big difference. If you adjust for patient characteristic in red, you have an attenuation of this difference. And if you adjust for center-related characteristic in blue, you have a greater attenuation, but there's still a big difference. When they tried to look at the center-related characteristic of transfer to hemodialysis or death, the only statistically significant association was the center size. So patients that were from a larger center had a lower risk of transfer to hemodialysis. So this is probably related to the expertise, the resources, more quality improvement programs. So we don't know exactly why, but it makes sense that these centers would have more expertise. We often thought about transfer out of PD or out of home dialysis, but we can also transfer into home dialysis. So this is the objective of this international study. So this is an ongoing study that is comparing registry from Australia, New Zealand, Canada, France, so Rhin is France, and US, and we also have UK, but we did not have the data at that point. And this here you can see the proportion of patients starting directly on PD in blue and directly on a home hemodialysis in orange. So you can see that it's quite small for home hemo, but it's between, it's probably 28% in Australia and New Zealand. So we know that there's a difference in different countries. What we wanted to assess in this study was the proportion of patients that were transferred from in-center hemodialysis to home dialysis every month after starting kidney replacement therapy on facility hemodialysis. And you have what we clinically observe in our centers, which is a second bump. So around 1 to, in Canada, 4 or 5 months, you have an intake of home dialysis in your patient starting in-center or facility hemodialysis. And this is important because we all have patients that will start acutely. They had no pre-dialysis or renal management follow-up, and these patients can transfer to a home dialysis. What is interesting is that in France, so this is the Rhin registry here, if you don't start directly on a home dialysis, you have a very low chance of starting home or being transferred to home dialysis after that. So this shows that even in countries where you have similar incident home dialysis, the uptake overall may be larger in US because they will transfer their patient to home dialysis. But it could be better. We can see that Australia and New Zealand, they have a higher proportion of transfer in blue, and they transfer their patient earlier than, let's say, Canada. So this means that they have less negative association with in-center hemodialysis. It also shows a missed opportunity to transfer in some regions. So if I was in France, I would for sure try to implement a transition care unit so that we can target these specific patients. Okay, so now let's deep more into the transition topic. We all know that our patient with kidney failure will have a lot of transition during their life. They will all transition from CKD to transplant or dialysis, and then within the different dialysis modalities and to and from transplant. I will mostly discuss transition from PD to home and transition from PD to in-center hemodialysis, but these are all different transitions. So for the last few years, I've been talking about how important and how frequent transition were in general, but we had no real data. So we decided to assess exactly what proportion of our patients in Canada had more than one kidney replacement therapy overall during their life. So here you have all patients that started dialysis in Canada between 2005 and 2018. We do not have preemptive transplant in that database, but we have all other patients. So from 61,000 patients, about 1/3 had more than one kidney replacement therapy. So 1 on 3 patients will have some sort of transition during their kidney replacement therapy journey. And this is obviously more important for patient on home dialysis. So 62% of patients on PD will have more than one dialysis modality or kidney replacement therapy modality, and 80% of those on home hemodialysis. And these are the number when we define the transition or transfer as 30 days of the new modality. It's even higher when we include any duration of transfer. So we have patients that will do 1 week of in-center hemodialysis because they have a cardiothoracic surgery. This was not included in our data here, but we have the numbers. And when we dive into the data, we can see that, for example, for PD patient, the most common transfer is transfer to in-center hemodialysis. So 45% of all incident PD patients were transferred at least once to in-center hemodialysis, and 27% had at least one kidney transplantation. Oops, sorry. For home hemodialysis, it's 80% of overall transfer and 52% of patients that were transferred at least one to in-center hemodialysis. So it's quite a lot. Patients that were younger had a lower burden of comorbidity, were from a minority race, and used home dialysis were the patients that were the most at risk of having more than one kidney replacement therapy during their follow-up. Why do we care about that? So I've said a lot of data, but we also know that for patient and their caregiver and different relevant parties, having a patient stay on home dialysis is important. So this is the result of the SONG-PD outcomes, which you likely already know. And you can see that in the core outcomes, we have technique survival. We know from a SONG PD work group that patient and caregiver don't like the word technique failure because it's associated with something that is negative with the word failure, but also because the technique doesn't really represent well how they live their dialysis. So we have to find a new word. It's difficult, and we don't have a perfect word yet. I like prolonging time on PD, or if we really want to talk about transfer to hemodialysis, it can be HD transfer or transfer to hemodialysis. So I think it's better to be specific. There's currently a ISPD time on PD work group that will try to standardize the definition and also targets that should be used in research to try to improve this important outcome. And definition may seem boring, but I think it is important because when we don't have specific definition, any words can be used. So there was a recent systematic review by Emma Alphick and Mark Lambie from UK, and what was shown was that there were 17 different definitions of technique survival that were used in PD trials, so that's quite a lot. And we also know that when you change the definition, you will change the outcome. So here I have a study showing data from Australia and New Zealand. And as you can see, if you change your definition of transfer to hemodialysis or technique failure from 30-day to 1 year, you will extend your rate of your proportion of patients remaining on PD from more than 6 months. So there's a real influence of the definition. So we often have outcomes of patients when we included a transfer to hemodialysis when they do 30-day or more. But there's kind of a black box about what happens early after a modality transfer, because most of the time in the study, this will be included to the previous modality. We do, however, know in clinical practice that there's a lot of things happening early after transfer. So this was one of our research questions from this integrated research group, where we used data from Canada, Australia, New Zealand, Europe, and US to try to assess the outcomes of patient transfer from PD to hemodialysis for 1 day or more. So really any transfer time. As you can see, patients were transferred about a year after starting PD or just a little over. This is a shorter duration of PD because, as I said, we only requested 1 day of hemodialysis to be considered as a transfer. And when we look at the detail, you can see here that, so this is crude mortality rate every 30-day period after the transfer. So red is Canada, blue is Australia and New Zealand, and then green and yellow are US and Europe. You see that the mortality rate is very high during the first 30 days, and then it kind of decreases at 60 days, and it slowly stabilizes. There's a big difference for the first 30 days between Canada, Australia, New Zealand, Europe, and US. I don't think it's because we are doing worse than the other. I think it's likely because US and Europe don't have good quality data for short duration of transfer. So we do know, for example, that in France, centers are requested to register a transfer if it's 60 days of treatment. So some transfer will be registered, but there's a selection bias and some will not be. I expect because of the complicated health system that it's the same in US, where short period transfer will not be included. So really here, the objective is not really to compare the registry, but to show the trends that early on, there's a high risk of death, and this risk is important, and then it will stabilize over time. So this early period is quite critical. When we look at different associations, so here the data is stratified by age. So the dot line is 70-year-old and older, and the solid line is less than 50 years old. And as expected, older patients were more at risk of dying, which is always the case. But as you can see, there's a kind of a disproportionate effect early on. So for the first 30 to 60 days, you really have a high mortality rate for our older patient, and then it kind of stabilized and the mortality rate is higher, but not as much. And this was seen in all the registry, even though where the quality of the data may not have been as good. We had the same pattern for the duration of PD. So patients that were on PD for more than 3 years, this is the dot line here, had a much higher risk of early mortality. And then after 6 months, it kind of merged all together. And this was the same again in all registry. So the solid line is less than 6 months, and the other one is 6 months to 3 years. when we did our adjusted model, and then we did meta-analysis, merging all the four registry, you can see that for risk of mortality, early on, for the first 3 months, patients older than 70 years old had a 5-time higher risk of mortality. Then it decreased to 3.7 at between 3 and 6 months, and the hazard ratio was 3.1 after 6 months. So older patients will always be more at risk of mortality, but their vulnerability is more important early on, and we need to be careful with that. So how can we improve the PD to HD transition? I just showed you that it's sometimes very dangerous, that patient may have a high mortality risk early on. It doesn't mean that we should not transfer a patient. Sometimes it's important to transfer a patient, and we do have some clinical inertia. So in my center, whenever a patient needs to be transferred, my colleague feel bad. They ask me, is it okay? I'm sorry, I transfer that patient. So it's okay to do it, but we also need to make sure that we don't transfer patients that are very frail and should perhaps more go into palliative PD or maybe consider dialysis withdrawal. So this is one of the things that we might have to reassess. The other thing is that obviously that previous study did not have all data about the reason why patients were transferred. So obviously some of these patients died because they had an acute health event that led to not being able to do PD at home, and then they died because of that event. So we are not assuming that the transfer is the cause of the mortality here, but there's an association, and it's just an indication that these patients are quite vulnerable. But transfer to hemodialysis is not always something that is negative, and it doesn't mean that it's the end of PD. So this is work that was presented by Louis Chaldevian, one of our nephrology fellows, at the Kidney Week this November. And what he showed is that for all patients that are transferred from PD to facility hemodialysis for more than 1 day, so here it's 2 days or more, patients are quite likely to return to PD during the first 8 months. So in fact, during the first 8 months, patients are more likely to return to PD than to experience any other health events, so including mortality or transplant, or being transplant or starting home hemodialysis. So a short transition to PD is not the end of PD, and we need to follow our patient to make sure that we allow them to resume PD. The longest your patient will stay on hemodialysis, the less likely they are to resume PD. So if a patient is still on hemo at 1 month after the transfer, their chance of resuming PD was 35%. This is Canadian data. After 3 months, it's 20%. After 1 year, you have only 4% of chance of resuming PD. So really, there's something up to 3 months, and you see here at 6 months, it's 10%. So we need to work and follow these patients closely during the first 3 months. And who are the patients that are more likely to return to PD after entering hemodialysis? So interestingly, middle-aged and older patients were more likely to resume PD. Younger patients usually stay more on hemodialysis. Female patient, minority race, patients that were on PD for a shorter time, which is likely related to the cause of the PD interruption, often more mechanical reason. And a patient that had a previous temporary hemodialysis period went back to PD and then again to hemodialysis are more likely to go back to PD. And this is probably related to the will of the patient to really stay on home dialysis, and they survive one transition, so they have that survivor effect. So what are the outcomes after a patient is transferred from home dialysis to in-center and back to home dialysis? We have data here from Australia and New Zealand, and this is related to home hemodialysis. So it's a little bit of a complicated figure, but it's just to show that they look at all patients that start hemodialysis. So they had 19,000 patients starting hemodialysis. Of those, 2,400 started home hemodialysis. 577 were switched from home hemo to in-center hemodialysis, and 171 were back to home hemodialysis. So we're looking here at the patient that were able to resume home hemodialysis. And as you can see, So you have the mortality rate after transfer from home hemodialysis to in-center hemodialysis. Just like we showed with PD, mortality rate is early on after a transfer to hemodialysis. So this is related to the risk inherent to the transfer and the reason why they transfer. But interestingly, those that resume home hemodialysis went back to their very low mortality rate. So the baseline is home hemodialysis mortality rate. So they did not carry a negative effect of that time on in-center hemodialysis. So this means that it's okay to work hard to have your patient back on home dialysis, whether it's PD or home hemodialysis. I think the outcomes are probably similar. I just wanted to touch base on these recent ISPD assisted PD statement paper, because I think that assisted PD is one of the tools that we can use to prevent transition to hemodialysis. So I know in Ontario, assisted PD is quite commonly accessible. I think that's amazing. In Quebec, we are working hard to have a similar program. So you're all quite familiar with assisted PD. And we had a chance to write an editorial on that statement paper. And in the center, you can see that one of the reasons why assisted PD is important is that you can prevent transfer to hemodialysis. We often think about assisted PD as a way to start PD, but in our center, we also use it a lot to maintain patient on home when their health state can decrease. Okay, so what about home-to-home transition? So you've probably heard about that integrated home dialysis approach, which is the idea that a patient with CKD may preferably start on PD if he or she is admissible to different modality. And then at some point, when PD is no longer the optimal modality for that patient, that we may plan or promote a transition from PD to home hemodialysis. This really builds on the advantage of PD early on, so with the residual kidney function, the ability to do incremental PD, smaller time requested for training, but then the long-term advantage of home hemodialysis was related to higher clearance and volume control, more liberalized diet, and so on. This is a nice model on paper, but it's not used quite a lot. So overall, we have about 3 to 5% of patients that will end PD and transfer to home hemodialysis. So here we have different registry data. It depends on the duration of the follow-up and how long we allow the patient after the end of PD to switch to home hemodialysis. But in Canada and Australia and New Zealand, it's about 5%. When we look at single center reports, there's a much broader variability. St. Michael's and Toronto published their data a few years ago, many years ago when I was still doing my fellowship in UHN, and they reported that 16% of their patients stopping PD were transferred to home hemodialysis. UHN recently published their data, and there the proportion is much lower, so you can see it's only 3%. We just had our data accepted as a short report, and our center has about 13% of the patient transferred from PD to home hemodialysis when on the total number of patients stopping PD. It's important to know that the practice pattern will influence these outcomes. So if a center is very prone to start directly eligible patient on home hemodialysis, then you may have less transfer from PD to home because you have more patients starting directly home. Our practice is that if a patient is a good candidate for both modality, we usually favor PD first because we feel it's easier. They may get a kidney transplantation. And if they still need dialysis, then we can do home hemodialysis later. So these are the reasons I think why we see that variability in the outcomes. And patients that were more likely to transfer to home hemodialysis in these single center reports were mostly related to the cause of PD ending. So patients that switched because we could predict that they would need to stop PD, so either inadequate UEFR clearance problem or sometimes mechanical problem, were more likely to transfer to home hemodialysis, younger patient, and those with a lower burden of comorbidity as expected. Similar predictors were found in our study looking at the ANDS data transfers from Australia and New Zealand. Again, shorter duration of PD, younger age, non-infectious cause of PD ending, because mostly it's because we can predict these ending. And then lack of cardiovascular disease and higher BMI, that's probably related to problem with clearance and sometimes ultrafiltration. Here you have the duration of in-center hemodialysis before the start of home hemodialysis in Australia and New Zealand. So you can see some patients stayed for quite a long term on in-center hemodialysis before they started home, and we stopped the cohort at 1 year. So they may have been even patients that started after that. But what are the outcomes? So this is becoming old data now. But when I was doing my fellowship in Brisbane, we look at the outcomes of patients that start directly on PD, patients that start directly on home hemodialysis, and then our transfer group that start on PD and then switch to home hemodialysis within 90 days. And as you can see here, and we matched these patients and included the duration of home dialysis before the match. So it was a complicated statistical approach, but as you can see, overall, the outcomes were similar for patients that start directly on home hemodialysis and those that start on PD and switch to home hemodialysis after that. And this is the patient and technique survival outcome. So this is very reassuring, I think, for patients that wonder what they should do if they are eligible to both home hemodialysis and PD. Their outcome is likely the same. Again, we need to be careful with these registry and their that kind of epidemiological studies, because we don't have any data on patients that were meant to transfer to home hemodialysis, but something happened and they were not able to do it. More recently, Louis-Charles Desbiens analyzed the Canadian data, again asking a similar question. So we included 163 patients that did PD and then home hemodialysis, and then 700 patients that did home hemodialysis directly using again a propensity score matching. We use different approach because they're always biased, so we try to minimize the bias using different strategies. So the first approach was an incident match. So we started a follow-up at the time of home hemodialysis start. So for patients that had PD before, that time was excluded from the model. And the other model was a vintage match, which is similar to what was used in the ANDS data previous study. So then we included the duration of the previous time on PD, and we matched patients that had a similar survival at that time. When we look at the data in the incident match, so when we only look at home hemodialysis, there was no difference in the cumulative incidence of mortality or transfer to in-center hemodialysis for both cohort. When we took into account the duration of PD before transferring to home hemodialysis, there was a small potential benefits for the switch group. So risk of mortality was lower for patients that start in PD and switch to home hemodialysis than those that did home hemodialysis directly. I think this is probably just related to selection bias, and I would be very careful with saying that this model is better than home hemodialysis directly. I think it just says that it's not worse and it's similar, so it's good for patients. We do, however, know that even if these are good patients and they have good outcomes and they will be able to stay on home dialysis when they end PD, any transition period is associated with some negative event. So here you have the rate of hospitalization of patients in that model. So in red, you have patients that were on home hemodialysis only, and in blue, you have patients that were on PD here and then were switched to home hemodialysis. And you can see that during the transition period, which is 1 month before, during the transition, and 1 month after the transition, the hospitalization rate increased, and then it will go back to the baseline. So you can see that data either positively or negatively. The negative way is to say that even if they have good outcome, they will be admitted because they had a transfer. So perhaps this is something that is not good. At the same time, even if they had a negative outcome with admission, they were able to go back to their baseline risk of hospitalization rate, which I think is a good thing. But we need to be mindful of that risk associated with any transition. So for the last few minutes, we will talk about patient perspective during the time of transition. So we know that patients care about mortality, but they don't only care about mortality, and sometimes they care more about other things than survival. So in the top 10 priorities for patient and caregiver in the SONG PD work, Many of the outcomes were related to what we call patient-reported outcomes, such as fatigue, flexibility with time, travel, sleep, work, impact on family and friends. We know that live participation is on the core PD outcome, which is the ability to participate in activities that are meaningful and important to patients. So it's kind of a more impactful way to talk about quality of life. Transition are important for patient and clinician. This is again from the SONG PD workshop or focus group. And you have a patient here that says that when you first go on dialysis, you feel horrible, but then over time it gets better. But you need to remember how bad it was at first, and that it did in fact improve, and that recall period is important and will influence how your journey is. And the second quote here is from a healthcare professional that say, we talk about what happens in to our patient when they are on one specific modality, so either APD or CAPD or PD to hemodialysis. But then we know that they change modality over time, so it's important to capture live participation during this transition period. So this was not me saying that, although I was in that group, but I think it's important. So what do we know about dialysis modality, mortality, and the quality of life after starting dialysis? So we have a lot of data about mortality after starting dialysis. We know that mortality is high early on, that it decreases over time. We know that some of pre-dialysis follow-up, renal management, some education will improve that mortality, access, and so on. But we have much less information about quality of life after dialysis start. Most of the study are cross-sectional, so they will look at what happened on what dialysis modality and this other, but they don't really follow over time. In my center, we did a small single-center pilot study a few years ago where we wanted to assess the quality of life of patients with advanced CKD, so with an eGFR of 15 or less. And we've had them fill a QD-QL-SF questionnaire every 6 months. And then we categorize the patient based on the dialysis modality that they chose, right? So blue is patient that chose home dialysis, and red is patient that chose in-center hemodialysis. We also included some patient that chose conservative treatment, but then switched back to hemodialysis. And as you can see, as expected, physical component summary. So physical related quality of life is higher for patients choosing home dialysis because often they are less frail, but and it's lower. For the mental component summary, it was stable at baseline for both, and you can see that it seems to increase for patients that chose home dialysis, and it seems to decrease for patients that chose in-center hemodialysis. And when we adjusted for different characteristics and follow that over time, there was a statistically significant association between choosing home dialysis and improvement in the mental component summary. This is interesting because it's not related to the choice of home dialysis, right? These patients did not start dialysis yet. So it's probably related. So I think it's important information because it's residual confounding, but it's probably related to their personality. It could also be how we follow them, how closely we need to make things happen. The process of care and involvement of the team may be different for patients choosing home dialysis because we need to prepare them. So we don't know exactly why this is there, but I think it's important to understand. And it's also important because some study have shown that there is a difference between what patients expect about PD in this case and what is real. So I think I'm still very motivated, but I used to be a young nephrologist, passionate about home dialysis that would do everything to convince my patient that they need to do home dialysis. And at some point, one of my old but very perfect PD candidate told me, you know what, you're not listening. I don't want to do PD. And it was kind of a realization for me that you need to listen to your patient, and we need to make sure that we don't push too much. So this is a study from Taiwan that assessed patients with using semi-structured interviews and asked patients how they feel after starting PD. And some of the themes were regret, but also discrepancies between the expected freedom and the convenience of PD and what really happened in their real life. And I feel that sometimes we may not prepare a patient enough about what will happen. So there's a fine balance between supporting our patient and trying to be there for them and facilitating home dialysis choice. But then at the same time, if we don't tell them the real exact expectation or what will really happen, maybe they can regret. And regret is not only something that happens with home dialysis. So this is a US study that did a regret questionnaire for mostly in-center hemodialysis patients, and they separated patients having low regret and high regret rates, or proportion. And then they did interviews for patients that were in the extreme, so high regret or low regret. And what they found was that patients that had low regret were mostly positive in life. They really integrated their dialysis into their identity, and they were most self-compassionate. And this is some of the characteristics that I think we see more within our home dialysis patient. So is it really the home dialysis modality or the characteristic of the patient that make them live better with home dialysis? So we don't know. So in the pilot study that I showed, our plan was to compare, well, it was to follow quality of life before dialysis and then after dialysis and show if there was any change over time. But then COVID happened and we lost a lot of our patients. So in the end, we only had 59 patients, that were analyzed, 36 that were doing in-center hemodialysis and 23 that were doing home dialysis. So we did not find any statistically significant change over time between home dialysis and in-center hemodialysis cohort. But as you can see here, when you look at the mental quality of life, blue is home, so blue is facility hemodialysis and red is home dialysis. So before dialysis, they were kind of similar, but maybe a little bit lower for home dialysis. They both drop at the time of starting dialysis, which is expected. And then at 3 and 6 months, you feel like maybe home dialysis patient will stay more higher, but we don't know. It wasn't statistically significant, so we don't know. In other countries, in other regions, they can do RCT to impose a modality for patient doing starting dialysis. So this is what we should do if you really wanted to answer the question, but then we could not do that in our context, because especially if you want to assess quality of life, you cannot impose a treatment that is so important in a patient quality of life and their today life. But anyway, this study from China showed that there was no statistically significant difference between patients doing PD or in-center hemodialysis in their region, although there was maybe a slight improvement in the symptoms of kidney disease with PD, sleep, and pain. But patient on PD had more rate of GI disorder, peritonitis as expected, and hypokalemia. So I don't know what to think about that study. What we did to try to answer this question is our qualified CKD2 home study. So there's a study that is funded by the Kidney Foundation that tried to mimic an RCD, but within our reality. So we included patients with an eGFR of 12 or less, and we follow them every 3 to 6 months before dialysis started, and then up to 1 year after starting dialysis. Our primary outcomes is change in quality of life and change in frailty, and we do follow patients starting home dialysis and in-center hemodialysis. We don't directly compare them because we know that there will be difference in patients doing both modalities. So it's not really to compare one with the other, but to see how the pattern will change over time and when different patients have different vulnerabilities or outcomes. We have a good engagement with this study. We have more than 160 patients recruited. More than half ended the study, so they did their 12-month visit or after dialysis. And then we still have about 20% that are before they did not start dialysis yet, and 25% that either got transplanted, died, or stopped the study at some point, but most after starting dialysis. But we also realized that there was important limitation within that study. So our sample size within the Kidney Foundation budget was 300 patients. So it prevented us from having subgroups that were important. For example, older patients with a high frailty level, what would happen for these questions? Also, this study was mostly based on health-related quality of life questionnaire, so we don't have all the important information, and we lack the caregiver perspective. So this led to a larger study that is funded by CIHR, which is transit care. So transit care has a similar approach, but it's a mixed method study that includes both some quantitative data. So it's similar to what I just said for patient, but we also have caregivers questionnaire both for burden of being a caregiver as well as quality of life. And we have interviews for patient and caregiver, so before starting dialysis and after starting dialysis, where we really try to complement the information that we could get with questionnaire. So we hope to have completed our recruitment by 2026 and have the result by 2028. So we are building on our previous cohort of 160 patients, and we do have about 60 new patients that are enrolled in that study. We are looking for more centers, so if you're interested, please reach out. And I think it's going to be important because it's our way to assess what happens to patients starting home dialysis or in-center dialysis in Canada and really try to answer that question about how their quality of life and experience change over time. This is just some preliminary data from the interviews that we did in our center for patients before they started dialysis. And here we did not really want to assess the choice of the dialysis modality, but mostly what happened after that. And so these are the 4 main themes that were found in our patients. So the first one was successive shock and announcement. So the fact that there's always something big that happened from CKD diagnosis to the need to imminently start dialysis. They highlight the personality type that influence the feeling linked to dialysis anticipation. So the being optimist or pessimist, having hope or despair, and then how they wanted to minimize the repercussion of dialysis on their lifestyle. So whatever they choose, home or in-center dialysis, it was how that could be merged into their lifestyle that was the most important, and also the importance of having a support network to increase their reassurance. Okay, so this is the work that we are currently doing to try to improve and understand how patients start dialysis. But if we go back to the transition between home dialysis modalities and in-center hemodialysis, how can we really improve that? The truth is that we don't have any high-level evidence about what to do to improve these outcomes. But my personal point of view is that we should guide ourselves about the data that we have for the transition from CKD to dialysis, because it's more or less the same thing. So we need to inform a patient, educate them, listen to them, and then start again. I also think we need to normalize modality transfer for a patient. As I showed you, for home dialysis patient, more than 2 out of 3, so more than 60% of the patient will be switched to another modality at some point, so that's important. We know from CKD data that education needs to start early, that patients are more likely to use home dialysis if they have a large number of CKD visits, that it's important to adjust the flow of information to our patient needs, and then that patient choice may change over time. This is a study from Ontario that highlight that more than 50% of patients starting dialysis did not have the recommended multidisciplinary care follow-up, which was defined by more than 1 year of follow-up before starting dialysis and at least 2 visits. So I think this can guide their approach in the sense that it takes time for patient to choose a modality and to be followed. And for patient that is on PD, and you may think that this patient will at some point need to change to hemodialysis, it's better to talk to that patient about home hemodialysis a few months in advance to make sure that you talk about it. You may discuss again. I usually try to say, I expect that within the next 6 months, we may need to change your modality, and you may have to transfer to hemodialysis. And in that case, we could try to do home hemodialysis. So you start to talk about it in advance when they don't need to transfer now, and then they can ask questions and they come again, and it gives them time. Patient really needs time. This is also an interesting study, again, for the choice of home dialysis when for patient with CKD. But it's interesting to see that more than 20% of the patients were never offered home hemodialysis. It was never discussed. And the reason why it was not discussed was mostly age and frailty. And we feel that older and frail patients cannot do home dialysis. And I don't think this is true. So I have in my practice many old patients doing home hemodialysis. Frailty sometimes may be more difficult for home hemodialysis, but age should not be a problem. Just last month, we transferred a patient from PD to home hemodialysis. He's 79 years old. He's been on PD for years, and he's now doing home hemodialysis perfectly. So age should not be a barrier to discuss home dialysis or to discuss home hemodialysis. And this is a slide about shared decision making in older patient. And I put that slide because a lot of our PD patient will be old, and we may think that they're old, so there's no point to discuss. But again, it's not because they're old that they cannot do something more. So we need to be mindful about the time that they may need, the knowledge that we should transfer, and then the discussion that can happen. So this is what I try to do clinically. So we have patients that are on PD, and then we try to optimize their prescription and make sure that they have a perfect prescription for their goals of care. And if this is all good, patient stays on PD. We do have patients for whom we may plan a transfer because we identified that they had a high risk of transferring to hemodialysis. Their clearance is not good. They lost all their residual kidney function. We are having high tonicity dialysate. And for these patients, when I feel that they will transfer within the next 6 months, I start to talk about home dialysis. If we can, we plan a fistula. I have to say for some patients, planning a fistula will be a big barrier. So we transfer them to hemodialysis and after we do the fistula. So I think that you need to readjust this scheme for your patient because it's not always, there's not a wrong or good way to do things. And when I can, so we have our PD and home hemo unit within the same floor. So we will bring a patient to the home hemo unit so they can see the nurse. We plan a visit, and this really helped them. But we will have unplanned transfer. Patients that have a refractory peritonitis, they have something that changed into in-center hemodialysis. And the first thing is to reassess if your patient can resume PD. So I've shown you that a lot of patients will resume PD, but in some case they may not. And there we tried, so we used to have a transition unit. Then because of staff problem, we lost that transition care unit, but now we have a sort of nurse navigator that will follow these patients and make sure that they have the optimal treatment. And not a lot, but some of our patients that transfer from PD to in-center hemo will end up choosing home hemodialysis at the end. So the key message, please consider end-stage kidney disease as a continuum of care. There is no good or bad treatment, but there will be a variety of treatment used by your patient, and it's important to let them know that this happens. Try to promote home-to-home transition and normalize modality transfer. Also prevent util transfer to hemodialysis when we know that mortality risk is very high. And then hopefully within the next few years, we'll be able to understand more what happens around transition period for patients starting home dialysis and also during the transition from these home dialysis modality. And then if you haven't done it yet, we have a survey looking at the practice pattern of patient on PD and those at risk of transfer to hemodialysis. So you can answer the survey through the QR code or from CSN emails. So that's it, and I will be taking questions. Thank you.
Fantastic. Thank you for that wonderful presentation and all that data that you showed. So if people have questions, please raise your hand and unmute yourself. But I can start. That survey, even I have that email. Do you want only a few people from the center to reply or more than one person?
Well, I mean, whoever feels that they are involved in home dialysis or PD want to share their opinion, it's okay. So there can be more than one person from the center, but
Okay.
you still have to take care of some PD patient or
Yeah. Okay. Yeah. So I'll make sure my home dialysis colleagues complete that for sure. Do you have a sense of, and you alluded to that with the transitions and the clinical outcomes when you transition, and mortality is higher in the initial period or hospitalization is higher, how much of that is fixable and how much of that is because of the reason, like the patients I think of are mostly, they became so sick they couldn't do PD. So that's why they were switched to hemo. Is that like how much can we actually fix? Do you have a sense of that?
It's very difficult, and we don't have good data to know that. I think from From clinical experience, there are two categories of, like, some patient will transfer because they are sick, something. I think the question should be, will transferring that patient to hemodialysis extend their life or extend their quality of life? So obviously, let's say your patient have a big accident, they are in hospital, they cannot do PD. This will happen and we cannot do anything about that. But the transfer that I think should be prevent are those frail patients that are like failing to thrive. They're not independent anymore. They are admitted for like failing to thrive, and then we say, oh, maybe we should try to transfer them to hemodialysis. I have never seen that type of patient improve their outcomes on hemodialysis. So usually they do worse on hemo than they did at PD. So this is what I think. There will always be some transfer, that's normal, but we should try to decrease those that we can prevent. There's also, like, let's say a patient had cardiac surgery. So we covered the Montreal Heart Institute, and they used to transfer all the PD patient to hemodialysis because surgeon and ICU doctor, they did not like the PD, and they put lines and everything. And then we changed that program, and now we can keep PD after cardiac surgery. So this is some example of transfer that may be temporary, but that will make a difference for patient, I think.
Yeah, for sure. I think even we have had that experience, and I think we are able to keep some people after cardiac surgery, but not everyone. There's always a fight with the surgeon.
Yes.
Yeah, because that perception is there, right? Oh, they all need to be on hemo. Can I ask about the you had this, I think you call it integrate, the database. So there is PDOPS, of course, but I think you have this is a much larger sample that you get, right? How would you compare those two? Because I think PDOPS only has the centers who participate in DOPS. This is different.
PDOPS is more extensive. PDOP is more extensive. They have more granular data. So this integrated initiative is it's registry data that we analyze in the different countries, but using the same statistical approach and the same research question, and then we pull together. So it includes all the patient in those countries, but we don't have as granular data as PDOPS which will be a selection of some of the centers, but they will have more granular data.
Right. And so you have a higher number, but perhaps just high level outcomes from.
Yes, exactly.
Okay, that's cool. And for the last question from me, if no one else is asking, the CIHR study that you are doing, that you're still enrolling it, you're still looking for centers, right? So it's possible that if I can push my colleagues that we might be able to participate.
Sure. Yeah. So it's basically following patient from eGFR of 12 or less every 3 months until they start dialysis, and then at 1, 3, 6, and 12 months. And if their caregiver want to be involved, but they don't have. Yeah. So we are still looking for some centers. So please reach out to me.
Okay. Oh, so there are a couple of questions in the chat that I missed. So Vail Hussain from US, he's asking about, do you know of any assisted home hemo services? And how do you think the home, the either assisted PD or assisted home hemo influence these transitions?
So we don't do assisted home hemo. When I was in US and years ago, they were starting some sort of assisted, but I think it was mostly for fistula, but I have to, like, for puncture cannulation. I don't know if this is still happening. I think the logistic of assisted home hemo is a little bit different. It may mostly be family assisted home hemo, which is what we've seen, but we don't do healthcare assisted home hemo. And I think, well, assisted PD, definitely patients that are using assisted PD will never transition to home hemodialysis, right? Because they have that assistance. For me, it's a different population of our cohort. It really increased our PD eligible patient, both for incident use and prevalent, because we don't lose patient anymore. Well, less patient. But these patients will not be able to do home hemodialysis with our current system.
Yeah, I think Ryan is saying in the chat that UHN is looking back at assisted home hemo maybe in early next year with PSWs. It'll be cool to see that experience in a few years. But he also is asking about the timing of education. So especially in the acute setting, sometimes it's very overwhelming, right? When they're hospitalized. We want to do early, but perhaps not too early. What do you think about that?
So when I present to our fellow, I present to them the first week of PGY4. I tell them that patients should hear about home dialysis at the first time we talk about dialysis. So when they will start, they are in let's say in the emergency room, they need dialysis. Yes, they may start on hemo, but we need to tell them we're going to start dialysis. There are two ways to do dialysis. You can do it at home or in the hospital. For now, we may do that, but know that, so we need to normalize home dialysis use. And if patient never heard about it for 3 months, and then they hear it, they're going to get used to what they do, and it's going to be one more thing on their life. So I think it can never be too late to talk about home dialysis. Obviously, you need to adapt to each patient, but I usually try to do it earlier than later. Same for patient on PD. I often tell them that PD will not be forever. Hopefully, they're going to be transplant, but we may have to change the modality, and this is normal and expected.
Right. And Dr. Last question, since it's already 9, if you have time. Dr. Zimmerman is asking about the people who are unlikely to be transplanted or who die need to know about the transition and going straight to home hemo.
Yeah, well, exactly. So this is what I try to do. So patient that start, so young patient that start PD for a reason or another, they cannot be transplanted. These are the patients that we will upfront say you will start on PD, but at some point we may have, or it's likely that we will have to change. I don't change my patient if we don't need to. So some patients have been on PD for 10 years, they're doing well, and that's okay. But if I feel that we are stretching too much PD, then I prefer to switch them. And we had good experience with that.
Yeah, I think the choice is really important. So thank you again for that fantastic presentation with all that data. I hope good luck on your ongoing projects. I hope Ottawa can be part of some of that. And again, this is the last rounds for the people in the audience, and we will meet again next year. Thank you.
Thank you very much for inviting me, and happy holidays, everyone.
Yes, Merry Christmas, everyone.
Bye.